TopMedTalk. Hello, welcome to TopMedTalk. I'm Andy Cumpstey, and I'm here again at the Evidence-Based Perioperative Medicine, that's the EBPOM World Congress here in London in the United Kingdom. And it's been a fantastic 3 days with lots of excellent speakers from all over the world. And I'm really delighted that a couple of those speakers have agreed to come and speak to us. Welcome back to the show, TJ and Tim. TJ, do you want to introduce yourself for us?
Sure. I'm TJ again, anesthesiologist. I'm currently the head of Division of Anesthesiology Critical Campaign at MD Anderson Cancer Center in Houston, Texas. Prior to that, I was at Stony Brook, and before that, I was at Duke University. I'm the founding president of American Society for Enhanced Recovery and past president for Perioperative Quality Initiative, or POQI.
Excellent. Thank you very much for joining us, TJ. And Tim?
Hi, my name's Tim Miller. I'm a professor of anesthesia at Duke, where I used to work with TJ, chief of what's called the General Vascular and Transplant Division in the Department of Anesthesiology. We look after patients undergoing a lot of major hepatobiliary, colorectal, urology surgery, as well as liver transplantations and vascular surgery. I'm also past president of ACER and on the POQI board, where I've been working closely with TJ as well as Monty and Mike and other members of the EBPOM community. So delighted to be back here this year.
Brilliant. Well, thank you both for joining us here on TopMedTalk. And again, you both mentioned it, but you're familiar faces at EBPOM, familiar voices on TopMedTalk. But I think we all have to say that the past 3 days have been a particularly good conference. What have been your highlights?
Yeah, I've been to EBPOM conference for many years, and I think this year in particular, I find that the program is amazing. It's a variety of topics, and we have representation from many different countries, different professional organizations focusing on cancer surgery, recovery from cancer surgery, AI, leadership talks. So I find it really refreshing to have new topics and new speakers. So I'm thoroughly enjoying it.
Thoroughly agree. I think it's as good a program as there's been at EBPOM. It's been fabulous. I've enjoyed the diversity of speakers. The all-female panel I thought was fantastic. Some of the surgery speakers, well, our speakers from leadership roles around the world, really, in the UK, Australia, the US. It's been a fabulous program.
And I think a recurrent theme throughout that program, whether that's been talking about AI, talking about leadership, talking about the cancer surgery, the recurrent theme about that program has been putting the patients first, and patient safety being first and foremost what we all do as perioperative physicians, which of course is paramount. And then looking at every stage of that perioperative journey, from the importance of risk assessing and stratifying our patients before they come into the operating theatre, the time we spend with them in the operating theatre, and then importantly, and picked up on by a number of speakers, that time immediately and longer after the operating theatre, that post-operative period. Why do you think that post-operative period has been highlighted by so many speakers as such an important part of that patient journey?
Yeah, I think first of all, I would say that what we do as anesthesiologists in the operating room, I think have a major impact on post-operative outcome. The close monitoring that we do intraoperatively and often minutes to minute, if not second to second, when you go to the recovery room, you'll find that monitoring step down to perhaps every 5 minutes, 15 minutes. But once they leave the recovery room, when they are on the general ward or floor, intensive monitoring goes now even further, and sometimes maybe every 6 hours. So you can see a rapid decline in terms of monitoring a patient. Of course, once they leave the hospital, there is absolutely no monitoring. And I think we know that many of the complications happen in the post-operative period and even beyond.
Yeah, completely agree. I mean, intraoperative anesthesia is heavily monitored, as TJ said, and very safe. We do a great job at looking after patients. We're there the whole time to look after them. And I think safety has improved dramatically over the years. Not necessarily the same post-operatively. I think it's an area that has huge opportunity. Can you see that in the hospital in 50 years' time, that if you're sick enough to be in hospital, you're sick enough to be monitored? And you have continuous monitoring of some variety that we can discuss, and possibly even when you go home. And when we have monitored patients continuously, we've seen that things like hypotension occur frequently, much more frequently than they do intraoperatively. So it's a great opportunity both for the monitoring and also for the location, I think, is also important, where patients go. And I think We've seen Guy Ludbrook and others speak about that, and different approaches around the world to how we should staff, both nursing staff and physicians, and monitor patients in the postoperative environment.
And TJ, you put up a really nice infographic during your session yesterday, which I think came from a paper by Professor Mark Edwards. It's either imminently about to come out or out already in the British Journal of Anaesthesia, but looked at different phases of that sort of journey and focused on monitoring and intervention being different. And there's clearly overlap, but they're not the same thing. So let's take monitoring first. What sort of things should we be monitoring in that postoperative period?
In the presentation that I gave is focusing on hemodynamic management of patients. And as we mentioned, we monitor patients very carefully. And also now we have a number of advanced monitoring techniques, particular monitoring of stroke volumes, cardiac output, so that we can determine the flow to the patients as well as optimizing oxygen delivery. Again, we do that well in the operating room, but I think sometimes after surgery, that we don't do it as well. And the other things to mention, while monitoring is important, we also need to take intervention to make sure that patients, in particular, when they have hypotension, instead of just giving drugs to increase the blood pressure, we need to ensure that the patient is adequately vascularly hydrated. Because if the patient is vascularly depleted with fluid, even though if you give a vasopressor, you are not going to be effectively increase the blood pressure. And the only way to tell us that is having advanced monitoring system. So that concept of goal-directed hemodynamic therapy, I think, is an important one. And that ensures us that to appropriately manage the patient with hypotension, as Tim mentioned, that is happen frequently. But what is the right approach to correct that hypotension? Making sure that is fluid, if it is adequate, before we start vasopressor.
And Tim, maybe we could just pick up on some of the points that TJ just talked us through very nicely. But firstly, what do we mean when we talk about this goal-directed hemodynamic therapy?
It means a variety of different things, and depending what the goal that you are, basically measuring flow as much as pressure. So if you can measure flow, you can measure stroke volume, then you can optimize stroke volume, and when you can optimize blood pressure. And as TJ mentioned, when you're looking at optimizing blood pressure, you're looking at the different types of hypotension that you can get, whether it's hypovolemic, whether it's low cardiac output, whether it's the need for a vasopressor. There's a variety of different phenotypes of both low cardiac output and hypotension that you can have. And if you have advanced monitoring, then you can treat the right patient with the right treatment.
So can you give us some examples of what these advanced monitoring systems might be or might look like, or any that you've got particular experience of yourselves?
Sure. We have really done research on most of the advanced monitoring system currently that are available, and they all use different principles, from the FIC principles. We also have looked at the stroke volume variation, pulse pressure variations. We have used esophageal Doppler monitor. We have used a bioimpedance device. It really doesn't matter which monitoring that one uses, but I think the key is to stick with a monitor to get the information from that monitor and then use that to guide therapy, whether it's managing fluid or managing hypertension. So it is all integrating the data that we get from advanced monitoring to help us. What is the best step? Even, for example, if you have a monitor that, let's say, for example, a brain monitor, for example, and we need to integrate the hemodynamic information to properly administer whether we want to deepen anesthesia or lighten anesthesia. For example, our classic teaching is that when you have a patient with hypertension, the patient may be light. And the knee-jerk response may be to increase our anesthetic level, whether it's inhalational agent or propofol. But that may not be the right approach. So integrating between hemodynamic data as well as brain function monitor is critical to best manage our patients.
So again, a couple of things to pick up on from that, TJ, but it's clearly a number of things we should be monitoring in this post-operative period. You touched on hemodynamics, brain monitoring. But as you said, it's not just monitoring it that matters. You've then got to intervene. You've got to use that information to do something. So what are the key interventions that we should be prioritizing or focusing on in that post-operative period?
There's several things there. Firstly, I think the number one thing that's going to come about is continuous or semi-continuous blood pressure monitoring in the post-operative period. And I can see that becoming much more commonplace in the first 24 to 48 hours in the next 5 to 15 years. And then it's having the patient in the right environment with the right team of doctors and nurses looking after them to have appropriate interventions, which are frequently going to be fluids and or vasopressors, occasionally inotropes. But a lot of post-operative units at the moment are not doing that, are not giving fluids at appropriate times, are not able to give a low-dose vasopressor if it's needed. So it's a combination of the therapies and getting the environment right for these, sick patients that don't necessarily need ICU care, but perhaps need a little bit more than ward care.
And are there any recommendations or standards or guidelines that you would point people towards to how to steer that actually quite complex problem?
I think there are. Over the past few years, the organization Perioperative Quality Initiative, or POQI, has put out a number of consensus guidelines, statements on what is the evidence in terms of managing hemodynamics, either intraoperatively or postoperatively. There are a number of new devices, and also with innovations, with AI, increasingly the monitoring capability beyond the operating room is increasingly available. I think these are some of the new technology we got to think about, especially if you look at, I practice in the US, the number of hospital beds has not really gone up over the past number of years, and it's not projected to go up significantly into the future. However, our patients are aging. There will be more and more patients needing surgery, and therefore more patients who are needing post-op recovery. But without the extra hospital bed, the promise or the opportunity is to have better monitoring outside the hospital, so that the patient, instead of being in the hospital, they can leave the hospital, go to an appropriate unit, but continue to be monitored.
And that fits very nicely with some of the work that Dave Selwyn was telling us about, again, on TopMedTalk, but also here at the Congress, about the NHS's new 10-year plan and moving from hospital to community. And how near to practice do we think that is? How soon are we going to be seeing that happening in our post-operative patients, do you think?
Globally, I think we're close. I think we're at the stage now where everyone is recognizing it's an unmet need. We've had significant publications for individual units doing this in slightly different ways around the world. And I think now people are at the stage where we're using conferences like EBPOM to come together. And I can hear, chat going on this week about how can we standardize this process, have guidelines. I don't think we're quite there yet at a even national, definitely not an international level, of what we think the standard processes should be for post-op monitoring of high-risk patients. But I think definitely in the next few years, it's the next real big current need.
But also, in addition, I think the surgical approach has also coming a long way. We have seen, surgery which was traditionally performed as an open procedure now being done laparoscopically, or more frequently now robotically. And that really changed the whole framework in terms of recovery time and the needs to be in the hospital. In my hospital, for example, prostatectomy, which only a few years ago tend to stay in the hospital 2, 3, 4 days, are now being done as a day case. So they go home at the end of surgery. But I think this needs to be matched up with more adequate monitoring beyond the hospital. I think with innovation, with apps, wearables, these are technology I think will improve our patient to be continually monitored, so they don't have to stay in the hospital. They can recover in their home environment, and also teaching not only the patient but the caregiver how to use this technology to ensure the safety of the patients.
Great point. And I think again, it's been really highlighted this week, the changes we've seen, not just with laparoscopic surgery, but the incoming of the robot and robotic surgery. And it's been highlighted in a number of talks about the learning curve that our surgical colleagues have been going on, bringing that robot work into practice. And maybe we're on a similar sort of learning curve with our monitoring journey. What do you think?
I think that's true. And I think it's also not just looking at the type of surgery, but how sick the patients are and individualizing it. And I think that's very important as well. And I was fascinated with some of the PQIP stuff that Ramani presented, whereas most hepatobiliary patients that should have gone to ICU did go to ICU because we're used to sending hepatobiliary patients to ICU.
Yes.
Whereas a lot of the GYN patients that should have gone to ICU didn't. There's much more red. And I think that's because people have a little bit higher barrier for sending a GYN patient to ICU because it's not normal. But if you have a sick patient and you risk stratify them appropriately, GYN patients, obviously, if they're sick, should go to ICU. And I thought that was some fascinating data that we can learn on to try and individualize our approaches.
I think part of it is also challenging dogma. I think, in medicine, we are typically conservative and we are a little bit unwilling to get out of our comfort zone. Enhanced recovery has taught us that there are a lot of things that we have been doing, which really, unless you think outside the box, we will still continue doing all those old practices like keeping NG tube, not feeding before patient have bowel sound. Now, all those through enhanced recovery program has really significantly improved postoperative recovery, shorter hospital stay, lower complications. I think the next step is to focus on how do we get a patient back to their preoperative baseline with sort of constrained resources these days, be able to recover safely, either in the step-down unit, increasing work being done now, as well as when they leave the hospital, to get them back to normality as quickly as possible and safely as possible.
Going back to your home institutions, what are you going to take away from this week back to your colleagues back home?
I've learned a number of new things that I can potentially take back to my institution, from rehabilitation phase, intraoperative, using modern techniques, technology to monitor, and more importantly, postoperatively, some of the new technology and new wearables that one can use. But overall, it's really trying to focus on what is the best way to take care of sicker and sicker patients, having more and more major surgery in a safe, as well as focusing on the patient's emotional needs as well, and also having adequate support system once they leave the hospital.
And for me, it's really what we've been talking about. In where I am in the US, we have many more ICU beds probably than a lot of centers in the UK. But equally, we have a big gap between ward care and ICU care. And I think exactly what we've been talking about for the last 20 minutes in terms of monitoring, staffing, environment. I would love to take away what people have talked about in this conference to try and see if we can close that gap and have an intermediate unit that I think would benefit a lot of our higher risk patients that don't need ICU care.
I completely agree with both those points. I think I'll be taking a lot of those points back to my institution at Southampton too. So thank you very much for joining us here on TopMedTalk. Really, really interesting discussion. And hopefully we'll see you at EBPOM in Ireland and then again next year.
Thank you very much.
Thank you very much.
As always, you can find TopMedTalk online on our website. You can hear this on our podcasters of choice, whether that's Spotify or iTunes or Audible or all the others. Please do follow us on social media, whether that's on YouTube or on LinkedIn. Hit the big thumbs up, give us a subscribe. It really does make a difference. And as always, a huge thank you to our sponsors, that's BD and GE, for keeping TopMedTalk free and open access around the world.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.